let's shift a bit to therapy right now. I mean, when we talk about low risk MDS, now that we classified the low risk MDS, the first question that I have in mind, do I need to always treat low risk MDS? Some folks say there are some folks that you could observe, some people would say maybe you could observe some folks. Where do we stand now in terms of the initial decision, observation versus therapy? And then we'll talk about therapy.
Yeah, so my approach to lower risk MDS, like I always say, I always take one step back. And my first approach, actually, or my first step, is to confirm that this is truly MDS, because sometimes you can get, dysplasia. And people often will say myelodysplasia when they talk about myelodysplastic syndrome. So dysplasia means abnormal maturation within the bone marrow, but this can result from many different things, from nutritional deficiencies, from drug effects, from inflammation, from autoimmunity, from other heme malignancies, etc. So I had patients, as someone who sees a lot of second and third opinion, I had patients refer to me with refractory MDS who turn out to have copper deficiency or
Oh,
B12
wow.
deficiency. Or you'd be surprised that, you think people are thinking about this all the time, but sometimes these things are not quite apparent. You have someone with gastric bypass and, chronically deficient of copper, but nobody checked for it, and they have cytopenias and they have anemia, and and there's dysplasia, and they think it's MDS, and nobody checked their copper, and you give them copper and they normalize. So I think the first step is to make sure that's the case.